Welcome back to my channel, and in today's video we are going to discuss something very crucial from the temporomandibular joint biomechanics. So far we were having a discussion about the anatomy as well as biomechanics of temporomandibular joint. But here in this video we are going to purely focus on to the biomechanics of temporomandibular joint. That is, we are going to see the functions in temporomandibular joint. Do you know how many degrees of freedom temporomandibular joint has? Or what are the possible motions in temporomandibular joint? Any guess? Yes, the motions include elevation, depression, protrusion, retraction, lateral excursion to right and left. So these are the movements, and when I tell about this movement, it's quite known that they are quite different from other joints in the human body, and we need a specific understanding on that. But we are going to do it in the most simplified manner, and let us discuss here the biomechanics of the kinematic movements of the temporomandibular joint in the Before going into the movements in particular, I want to give you some infos about the temporomandibular joint. That is, the temporomandibular joint is one of the most mobile joints in the human body. It is one of the most frequently used joint also in the human body. We use it for swallowing, we use it for speaking, we use it for what you call mastication. And of course, there is very little time in our day-to-day life where we keep it silent. Maybe that's when your teacher asks you some questions. Whatever it is, this is highly mobile joint. And of course, you know, a mastication like biting a chicken leg or a chicken piece, etc., requires tremendous force. So this joint is highly mobile. This joint is frequently used. This joint has a great degree of force requirement. It is subjected to greater stress like chewing. And of course, you know, like mastication, which requires tremendous force, bite force is needed. But speaking, it requires very fine control. We can speak we can speak a lot of words in a very little time. At the same time, we can speak slowly. We can raise our tone, we can sing a song, etc. So this requires some fine control for all this activity. Your larynx is playing the role, I don't deny that, but still there is a fine control needed. So this all puts a great degree of demand, stress on your TMJ. But your TMJ has a unique structure that is known as its fibrocartilage. We discussed that the TMJ is lined by not hyaline cartilage but the fibrocartilage. And fibrocartilage has a peculiarity, that is, it can withstand wear and tear. At the same time, it can remodel. And that's a point here. When fibrocartilage can remodel, the temporomandibular joint can be used again and again, and it sustains for a long period of time without much degenerative points. Right? That's all about a general introduction, where you need to remember you have a beautiful structure of fibrocartilage which is specifically adapted for your increased demand in your temporomandibular joint. Yes, and now it's time to step on to the movements in temporomandibular joint. The first one would be, yes, elevation and depression. Elevation and depression. Usually, we have a strategy. Like we study the flexion, we go for extension. We study abduction, we go for adduction. We study medial and then for lateral. Whatever it is. But here, we have a reverse approach, that I will focus first on the depression, and then from the depression, we move on to understand the elevation. We need to have some certain pictures in our mind. Let us just have it. Like we know that the temporomandibular joint here, you have the mandibular fossa over here, right? Yes, you have the mandibular fossa. Here you have the articular eminence, right? We have the articular eminence. And then here you have the condyle, mandibular condyle. You have the mandibular condyle over here. right? Mandibular condyle. Very good, very good. And then you have a unique structure in your TMJ which plays a crucial role. What is that? What is that? Yes, your articular disc. The articular disc in the temporomandibular joint, which is almost like a biconcave shaped disc we have here. Yes, yes, yes. And of course it's attached to your, like, you know, the muscles like lateral pterygoid, etc., which is not discussed, not to be important at this point, right? And it is attached posteriorly to the retrodiscal lamina that you need to know. We have a superior lamina here. I hope you are remembering this one. And if you are someone who is watching this for the first time, kindly go on to the old video and then just check back to this one. Yes, you have a retrodiscal lamina like this. Now we need to know what is the motion possible. So mandibular depression, you know, this is the movement. Very essential for opening your mouth to have something or to speak. So this is mandibular depression, and mandibular depression is actually occurring in two phases. The first one is that the initial phase of mandibular depression, when you open your mouth, when we open our mouth like this, the first thing that is going to happen here is actually happening in the inferior joint. What is that inferior joint? Yes, this one is your inferior joint. This one is your inferior joint. This is the superior joint. This is the inferior joint. The motion is going to happen in the inferior joint. What motion? Your mandibular condyle will spin in a clockwise direction. Your mandibular condyle will spin anteriorly, right? Anterior spinning of the mandibular condyle is the first movement when you open your mouth. So when we are going for a mandibular depression, the first movement would be, that is the spinning movement, the spinning of condyle on inferior joint of the mandible. Inferior joint. Inferior joint means condyle to the articular disc. So initially your mandibular condyle will not go for translation, will not go for posterior translation or sideways excursion movement, but purely it will go for a spinning movement. That is a pure rotatory motion happening in that region. That is a pure rotatory motion, right? That is in the initial stage. Now when this movement is going to happen like this, it is going to open your mouth. When the mouth is getting opened, immediately the movement will switch on to the superior joint also. The movement will shift on to the superior joint also. What will happen? This entire structure, your disc and your condyle, will go for anterior translation. The disc and the condyle will go for anterior translation. You know that depression is requiring anterior translation. So definitely in the superior joint, the disc as well as the articular condyle both act as a disc condyle complex, and this will move for the anterior translation, right? It will move for the anterior translation. So at the initial degrees of your freedom of depression, it's a pure spin, clockwise spin. But when depression progresses, the spin or the rotation is accompanied by a simultaneous or simultaneous. Some studies say that it is simultaneous. Some studies say that this occurs sometime and then later this. But let us take it as simultaneous. A simultaneous anterior translation also. So two motions, that is a spin plus simultaneous anterior translation in later stages. That is how this sort of movement of the depression is occurring. Am I clear? Yes. Am I clear? That's so simple. Yes. Only thing that you want to remember, there are two joints and two possible motions. First one is a pure spin motion, and pure spin will open your mouth to a few degrees. It won't open more than that. If you want to open more than that, because you know that the mandibular condyle is having a very less surface in the mandibular fossa. Our main articular surface as per our biomechanics discussion is which one? is our articular eminence. So this has to move to the articular eminence. For accelerating that move, a translation is going to happen. A translation in this direction, an anterior translation along the direction of the slope of articular eminence. That is your mandibular depression, right? Yes, very good. That's so simple. And what about then the dip, elevation of the mandible? The X-hat opposite. Initially, there will be anti-clockwise spin. That is a posterior spin. And at the same time, here you will have the posterior translation on the superior joint. So that is simple. So elevation means it will have what you call a posterior spin plus, this is happening in the inferior joint. We studied that, yes, plus a posterior translation in the superior joint. That's all about the very complicated motion, the antimandibular elevation and depression. And of course, you know, the mandibular elevation and depression is about 40 to 50 millimeter. 40 to 50 millimeter means 4 to 5 centimeter. But functionally, people ask you, the clinicians ask you to observe your mandibular depression. They ask you to place your knuckles, okay, knuckles of first two finger, the metacarpal, the interphalangeal joints, okay, the proximal interphalangeal joint. Ask you to place it over here, and if you can place it 2 fingers, it's normal. If it is 3 fingers also, it's normal. Only you need a 2 finger placement for your functional task, but many of us can do the 3 fingers too, but not more than that. If it is no more than that, it is a problematic one. If it is less than that, you don't have a functional range of motion for elevation and depression. So you can place simply your 2 fingers between your upper and lower incisors, that is the central teeth. Normal. Sorry, functional. 3 finger. Perfect, normal, no problems, nothing to worry about if you have a 3 finger. I cannot completely make a 3 finger one. 2 is sufficient for your functional range of motion, right? Yes. And what about your mastication? How much millimeter you need from this one? 40 to 50 millimeter. You hardly need 18 millimeter, that is 1.8 centimeter is needed. You don't need a big opening of mouth to swallow, but you just need an 18 millimeter. So this is a normal elevation depression is about 40 to 50 millimeter. 18 millimeter is the functional thing that you need for mastication. And clinically it is established by placing your knuckles of the fingers, first 2 fingers, the interphalangeal joints, in between your upper and lower incisors. If you can place 2 in knuckles, that's fine, perfect. You have a functional one, and if you have 3, it's okay, no problem, normal. And if you can't place even 2, that's a reduced range of motion, and greater than that, it is a laxity of that joint, which is very rare, okay, right? Yes. And some studies says that this rolling occur only a very minimal value. Rolling is occurring exactly speaking about 15 to sometimes 25 millimeter of this range of motion. Rest is achieved by your translation alone. So rolling is having a very minimal value. Some studies says 15 to 25, some studies says 5 to 25, etc., which is not much needed for us. As far as what I want you to get into your mind is like that the rolling is not a predominant movement, or the spinning is not the predominant movement. The functional movement is achieved by your greater anterior translation, because you know that in this it can roll only at this much manner. Okay, it can have a maximum that much, but the major roll or the major proportion is to be by your articular eminence, which is very crucial in this joint. So to move to the articular eminence, you need anterior translation. So anterior translation occupies a greater role of the mandibular elevation of depression, right? Yes. Now we have certain factors that govern the mandibular elevation of depression. Let us just see that some factors that have a very crucial role in mandibular elevation and depression. What are the factors? Some factors having a very crucial role in mandibular elevation and depression. Some factors. Yes. Those factors include the first one, your muscle attachment, that is your lateral pterygoid muscle. Lateral pterygoid muscle. Your retrodiscal lamina. Your retrodiscal lamina, right? Your retrodiscal lamina, right? Then your biconcave shape of disc. Biconcave shape of disc. Then The other factors include some muscles like masseter, temporalis, medial pterygoid, means all the muscles, medial pterygoid, attachments of your disc, attachments of disc. So these are some factors which can regulate your, what you call, the motion that is possible in the temporomandibular joint. For example, let us have the diagram itself, a quick one. Okay, no, not that one. We need some more space for that. Let us draw it somewhere here, like this. Yes. Yes. This is the mandibular fossa. This is the articular eminence, and here you have your disc. Yes. And here you have the, sorry, that is a condyle, and this is the disc. Okay, and this is the disc. Disc is attached anteriorly to your lateral pterygoid muscles here, and of course here back here you have your retrodiscal lamina, the superior and inferior lamina. The lateral pterygoid muscle, you see that this is anteriorly attached to the disc, so it can help in the anterior translation. So the lateral pterygoid muscle can help in anterior translation. At the same time, it can help in posterior translation also. How? Posterior translation, because this muscle can eccentrically relax. That eccentric contraction of this muscle can help in posterior translation. That means this muscle can help in depression and elevation also. This muscle can help in depression as well as elevation. Whereas your retrodiscal lamina, you see that this one here is elastic, superior one. This one is inelastic. Inferior one is inelastic. We studied it earlier. So this inelastic one will resist the anterior translation. Inelastic one will resist the anterior translation, whereas your superior elastic portion will help in posterior translation. That is, it is divided into an inferior one and a superior one. Inferior one is inelastic, therefore it resists the anterior translation. Superior one is elastic, therefore it produces posterior translation. Your biconcave shape of the articular disc, because this is very essential, since it is having this biconcave shape, the mandibular condyle can freely move, or the mandible condyle disc also can freely move. So the mobility is greatly achieved by your mandibular condyle. And finally, your masseter, temporalis, medial pterygoid, etc. muscle. You know the masseter muscle is attached like this, okay? So it can help in opposing the pull of your lateral pterygoid muscle. The temporalis and medial pterygoid muscle also has some role in your temporomandibular joint elevation and depression. They all assist in this role. And finally, the attachments of the disc. You know that the disc is attached to what you call medially and laterally. The disc is attached to the synovium. Medially and laterally disc is attached. Anteriorly, posteriorly, we studied that one. So this attachments of the disc also resist the rotation that is possible. It cannot freely rotate. That is why we saw that the rotation is very minimal in this joint initially, and it is happening only in the initially, whereas the greater amount is contributed by your translation movements. That's all about just the details of the biomechanics of anterior and posterior translation or elevation and depression of the mandibular condyle. Let us see with this bone, actually, a skull. You know that this is how the joint is articulated. So initially, at this degree, you can see that initially for the mandibular elevation, what is happening? Depression, what is happening? For initially mandibular depression, there is a pure rolling. You can see that there is a pure spinning in the anterior direction. There is no translatory movement. So initially after this, immediately there is a translation. You can see that the disc as well as the condyle moves together anteriorly, and as it proceeds, the elevation and depression is achieved. At the same time, your depression is carried by a posterior roll, and at the same time, a posterior translation to your back position. See, once again, so this is the thing, and this is the mandibular depression, and this is the mandibular depression and elevation. So in depression, you have an initially a pure rolling, pure spinning, and an anterior translation. Same thing opposite occurs in the elevation. So that's all about the elevation and depression. And now it's time to move on to the second motion. That is your, what is that motion? What is that motion? Protrusion and retrusion of the temporomandibular. This is very simple when we compare it to the other movement, protrusion and retrusion, right? Protrusion and retrusion. Yes, what do you mean by protrusion and retrusion? This is this simple movement, moving your mandible condyle anteriorly. protrusion. Okay, moving it posteriorly, a retrusion. See that? That's a beautiful movement. That's a moving it anteriorly is protrusion, moving it posteriorly is your retrusion. Right? That's all about that movement, and it is very easy for us to understand also. Let us just draw the diagram. So there is no spinning, no such movement, and this joint, this movement occur in the superior joint too, not in the inferior joint. What happens is that during your anterior translation, that is your protrusion, your mouth has to move forward. What is happening? There is a pure anterior translation. There is an anterior translation. There is an anterior translation. But is it just an anterior translation? For example, you see this much only it can go for anterior translation. Then this is the direction of the articular eminence. So it is an anterior and inferior translation. It is an antero-inferior or anterior and inferior translation. See, that is simple. I think like you see here you can move anteriorly up to this much. It's fine. But here you have your articular eminence, which is like a slope over here. So it has to move inferiorly to complete the motion. So this comes an antero-inferior motion. So it comes to be an antero-inferior motion. So during protrusion, the mandibular condyle will move in the superior joint antero-inferiorly. Whereas in retrusion, what will happen? It will move the exact opposite, that is postero-superiorly. That is the postero-superior. This is the superior direction. This is the posterior translation. So we can tell it like postero-superior translation. Postero-superior translation. I think that's so simple. Yes. Let us see with the help of bond. And you have this one. Okay, over here. And this is your anterior, protrusion, the mandibular condyle moving anteriorly. This one is your protrusion and this one is your retrusion, from there to the normal. Okay, so the protrusion, you see, for the protrusion to happen like this, you can see that there is no spinning or anything like that. You don't need any spinning or any movement like that. You just need this mandibular condyle from moving from the mandibular fossa to the articular eminence. So this is an anterior translation. So this one is a pure anterior translation, this one. But you can see that this is a slope over here, and it cannot move anteriorly more than that. So this anterior translation will be accompanied by an inferior translation. So it will be an anterior first and an inferior, antero-inferior translation. So this is protrusion. It will move anteriorly. From there it has to move posteriorly. That is a posterior superior translation. That's so simple. That's protrusion and retrusion. And normally we can estimate like if there is a normal protrusion, our lower jaw, that is your lower teeth, should come in front of your upper teeth. It should come few millimeters actually. But need not worry. If it is functional, you just need it to come at least at the same level. Upper and lower incisor should come at least the same level. If you can't hold it in the same level, it's an abnormality. But we can have a an anterior movement, even a few millimeter for few people. But I don't think I can move few millimeter. Maybe my upper teeth are a bit protruding anteriorly. Yes, whatever it is that. So that is the functionally you are able to move it a few millimeter anteriorly. But even if it is touching the upper and lower equally, usually at the resting time the lower is at back side. So upper and lower, if it is able to rest in a normal position, that's fine. You have the normal range of motion. And retrusion, about 3 millimeter you can go for retrusion. And here too, 3 millimeter you can go for a retrusion. Retrusion is often limited by your ligament over here, the temporomandibular ligament, and protrusion is accelerated or taken on by your retrodiscal lamina. It helps in the stretching of the retrodiscal lamina, help in anterior translation. If it is resisting or if it is less stretching, it is of course resisting your movement. And this protrusion is very important component of the depression, because you know that normally in functional range of motions we don't simply go for protrusion. I will eat my food only with a true protrusion. No, it's not like that. It's a combination of movement. I'll speak with a combination of movement. So this elevation depression is actually accompanied by your protrusion, because you know that anterior translation was there in the other one. Yes. Similarly, elevation is accompanied by your posterior translation, that is your retrusion. So elevation depression is having a very important support, or does need a very important support from your protrusion, whereas elevation requires a support from your retrusion. So these are very important to each other. So that's all about the retrusion and protrusion. Protrusion is something like an anterior translation, so which cannot purely occur in the anterior direction due to the articular eminence. So it's an anterior inferior translation. This is a superior posterior translation, posterior superior and inferior translation on the protrusion and retrusion. And finally, the last movement that is to be understood, that is your lateral excrusion. That is your lateral excrusion. Lateral excrusion, and it can be to right lateral excrusion and it can be left lateral excrusion. Usually it is about 10 to 11 millimeter. Usually it is about 10 to 11 millimeter. What do you mean by excrusion? This movement, this transverse plane movement, both sides. This is excrusion. This is right excrusion. This is left excrusion. Usually it is about 8 to 11 millimeter. It can be between 8 to 11 millimeter. But functionally it is sufficient if during this lateral excrusion, this lower can move at least one incisor gap. You have one incisor, the width of the one incisor, at least this much it can move. If it can move, it is normal. If it can move to the left side, at least one incisor gap, the center incisors can, in the lower side and the upper side, can differentiate between a one incisor gap. It's fine. Usually it is 8 to 11 millimeter, but you don't need that much. You might need this hardly 2 or 3 millimeter. But people like me who have a very broad incisors can find a difficulty in that moment, but need not worry, that's not a functionally what you call a very significant one, that can reduce your range of motion. No need to worry about that. But we need to understand how excrusion is happening. This is just excrusion, lateral excrusion. This is just medial excrusion, left excrusion. But is that all? How the biomechanics of this movement is happening, and it is a bit confusing, but we'll do it in an easy manner. We'll do it in an easy manner. See, in this bone, for example, this mandible has to excrude this way to the right side. This has to move to the right side. Please have a complete attention, because only then this is going to be easy. This need a right side excrusion like this. Okay, it need to move right side in this frontal plane. So you know that if it is in the frontal plane, which will be the axis? That will be a vertical axis. So if the mandible is to move to the right side, the right mandible or the ipsilateral condyle, same side condyle, will rotate in the vertical axis. See, only this much motion will be possible in this ipsilateral condyle. Only this much motion will be possible in the ipsilateral condyle. But what is happening to the contralateral at the same time? It is going for anterior translation in the articular eminence. So here only spinning, but here you can see that no spinning but an anterior translation in the articular eminence. So what is the summary of that? During right lateral excrusion or an excrusion to one side, the same side condyle will rotate vertical on a vertical axis. At the same opposite one will go for an anterior translation. Are you able to get it? Because you know that if here this is just vertical rotation is happening, it can only move this much. If the same rotation is happening here also, this is only the movement that is happening. But we have a tremendous movement over here like this. We can move it in the frontal plane this much. Okay, we can move. For that, this one should go away from it. It should give away. It should give away in this direction. That is from the mandibular condyle. It should move anteriorly. It should go for an anterior translation. When both of that is accompanied, you have the right lateral excrusion. Right? Is it clear? Let us see with one more example. For example, your left side is going for excursion. So left side it is rotation. But what should happen to the right side? The right side should go for an anterior translation. The right side should go for an anterior translation. If this is accompanied, then you look at my index finger, it will move away. It will go for the lateral translation. If this is also rotating, it will not have the movement. So in order to have the movement, the contralateral side will go for anterior translation like this, then anterior translation in this direction. Right? Is that okay? That's all about your what you call the lateral excursion. If lateral excursion is happening to one side, the same side mandibular condyle will go for rotation, and opposite side mandibular condyle will go for anterior translation. Should I confuse? May I confuse you again? We have one more movement here. This is a frontal plane, this is a transverse plane movement, that is only this much, transverse plane. But of course, you know that in our day-to-day life, when you are eating something, we have a movement like this. Okay, that movement is actually occurring in the which plane? Which is this plane? This plane, sideways plane, that is the frontal plane. So that movement should occur in the frontal plane. How that movement will occur in the frontal plane? The excursion to the frontal plane, how can it occur? To occur that, the same mandibular condyle, the ipsilateral mandibular condyle will only rotate. It will not go for anything else. But this one will not go for anterior translation. If it is going for anterior translation, still that will be in the transverse plane itself. But it will go for depression. It will go for depression. When it is going for depression, it happens to be the frontal plane. You can see that now. You can see this is the sagittal plane. This head is resting. Now this is the frontal plane. This is the frontal plane. Sideways movement like abduction. But whereas the opposite one, which we discussed earlier, if it is only anterior translating, this is the only movement possible. That is in the transverse plane, medial and lateral rotation. Similar to that, anterior, lateral and medial excursion. Lateral and lateral excursion to right and left side. But if it is going for depression, you can see that if it is going for depression like this, not this much, I am just exaggerating, it can go for a frontal plane movement. If here depression is happening, this can go for a frontal plane movement. That is the second combination of movement, where if the movement is happening in the frontal plane, ipsilateral mandibular condyle will go for the same rotation. Okay, but contralateral will go for the depression. If this movement is happening in the which plane, that is in the transverse plane, the ipsilateral will go for anterior translation, whereas contralateral will go for posterior, rotation. Sorry, ipsilateral will go for rotation and contralateral will go for anterior translation. If you are confused, this is enough. This is the lateral excursion, but this is just a modified movement of that, which we use in our functional activities. You need not focus on that. You need not worry on that. But that's simple. It's very quite simple because it's just this much. Rotation over here, but here it is an inferior depression. That is a depression. Here it is the if rotation is happening in the opposite side, here it will go for the depression like this. So it will happen in the frontal plane. Right? That's all about your mandibular condyle movement. Let me know if this was easy for you or if it was tough. But I believe that this is very simple. And in the next video, we are going to finish our discussion on the mandibular condyle, the temporomandibular joint with the biomechanics and pathomechanics, some clinical conditions on the temporomandibular joint. Until then, stay tuned and we'll see on the next video. At the same time, we are going to start our ankle joint biomechanics also in the upcoming videos.